means in 20 seconds, we're going to go live to however many CFRs we've got sat. There we go. Welcome. It's really lovely to see so many of you. It's standard. I was stood here at 4 o'clock this afternoon going, no one's going to turn up. I'm going to be sat here on my own. And then Emily walked through the door and then you all started walking through the door. So welcome. It is genuinely so lovely to see you all. This is our second CPD event, which is amazing because it means it's working and we've got people back and you're here. We've got a really packed evening and hopefully it's going to work. And I was talking to Emily, who was our new resource officer, and we're going to make it work and it's going to be brilliant and you're going to learn so much. A little bit of housekeeping. If you haven't already, if you could sign in on the register at the very front of the building, just so that we know you're here in case we need to evacuate. To the people online, welcome. Obviously, no need to sign in. We know you're with us, which is lovely. Bit of housekeeping with regards to toilets. You can access the toilets just off to my left-hand side. Tea and coffee. We've got cake, which is amazing. One step up from Harlow. So you've actually got cake and biscuits and tea and coffee, which is lovely. And that's thank you to our charity. So thank you to Kate, who's with us as well, which is really lovely. First of all, what I want to do is just say a big thank you from me to you. I know a lot of you because it's my area, but the people that I don't know that I have met are the new clinicians that I've come across. So this is huge because I've met Luke and I've met Emily and I've met so many other people, and it's just lovely to be able to have that connection from the volunteer world into the clinical world as well. So this is what we're trying to hope to achieve. So lots to do, lots to talk about. We've got no fire alarms happening. If there is, fire exits out the way you came or out the other door behind where the tea and coffee is. Other than that, what I would like to do first of all is welcome you very happily to Mr. Tom Abel. Please come forward, sir.
Thanks, Liz. Before I say a few words, I just wanted to say a really big thank you to Liz, because putting these events together is not a mean feat by any stretch of the imagination. And so would you all join me in just a quick round of applause for Liz? I'm Tom Abel. I'm Chief Executive of the ambulance service, and I think firstly I just want to say a really big thank you to all of you for selflessly giving up your time to look after your local communities and support local people. The work that you do is absolutely essential and so important. We know that cardiac arrest survival rates in the UK aren't as good as they need to be when you compare us to other countries, and a lot of that is around the speed at which we get bystander or first response to people. And you're making real difference here in the east of England to help actually save lives and improve lives and reunite people with their loved ones. And that's a phenomenal thing that you do day in, day out. And I'm also really looking forward to joining you because I'm doing my course in a couple of weeks in Ipswich. And so I can see what it's really like. The thing that we are committed to do within the ambulance service is to support you better. I recognise that we haven't always done that as well as we should, and we haven't recognised the contributions that you've made in the past. And obviously we've been working hard at starting to try and address that through events like this and some of the other things that we've done over the last couple of years or so. But I do recognise there's still lots more we can be doing and should be doing. And so it's really important to get your feedback on what else can we be doing as an ambulance service to support you, support your groups, and to help really, continue to advance the really important work that you do for the communities, because ultimately that's what we are all here for, is to look after the people of the east of England as best as we possibly can, despite the pressures that we undoubtedly face. This winter is going to be a tough one. I think we all know that. And so actually that makes the role that you do even more important. And one of the things I'm really excited about is that we are working really hard to look at what we can do to give you additional skills and additional competencies. And so to help address and respond to some of that demands. And so we can look after our communities better together. So a really, really big thank you from me. I hope you really enjoy the evening and get lots out of it. And the second one, and there's going to be many more to come. Liz?
No.
Well, Liz might need a break. We might need to find somebody else to do that. But I think getting your feedback at the end of this in terms of what else you would really like us to put on would be really helpful, so we can make sure that these events are really helpful for you, kind of give you additional skills that are interesting, and everything else. So yeah, a really big thank you for me. Enjoy the evening, and I look forward to seeing some of you out and about over the coming weeks and months. So thank you.
Thank you. Thank you. So let's start, shall we? Let's start at the very beginning, and the very thing that we're going to start with is making sure that we understand that whilst tonight is a bit of a learning experience for all of us, including myself, what we just need to remember is that we are just keeping in mind our scope of practice. So I'd like to really quite nicely welcome our new CFR training manager, lecturer practitioner, Mike Willis, to the stage, who is going to talk through your scope of practice. So if you give him a big welcome.
Thank you very much. So obviously cardiac arrests, there's lots that goes on, there's lots that happens. And the important bits are generally the bits at the beginning. There's lots of people involved, there are lots of skills involved, but if we don't do the basics right, then none of it is worth anything. So the absolute beauty of a CFR and bystanders is that they only have that one task. So when we think about scope of practice, we're just looking at what you need to be good at doing. And then, as Tom said, if there's any additions to that, that's great. But the basics are the important bits. So in terms of adults, because we go to adults and pediatrics, but with the adults cardiac arrests, we are first of all going to be making sure we know that they are unconscious or unresponsive. Obviously, if they say hello to you as you walk through the door, happy days. So we give them a good shout, we give them a good shake. Obviously, then, if they don't respond to us, we need to think, are they having an obstructed airway? Is their airway open? So depending on the circumstances, if it's a traumatic case or not, we're going to do a head tilt chin lift, or we are going to do a jaw thrust. It is important to look in the airway first. If they were about to choke, or if they've got a good lump of something in there, have a look first before you open it and push it down further. Really good idea. So we're going to open that airway up, and then we're going to assess for breathing. So in terms of breathing, it's not are they or aren't they? Is it normal? So you can have gasping, agonal breaths, but the question is it effective or is it ineffective? So we're looking for those 2 good effective breaths in 10 seconds. And if there is a no to that question, then we are going to confirm a cardiac arrest with control if they don't already know. And then we are going to get our AED on. So there are different types. You all know your own. If it's out of a cupboard, they're thankfully quite simple. There are pads generally in the back. You open them, you stick them on. There are stickers in there. We're then going to listen to the voice prompts. Generally, it analyzes for a bit. Sometimes they talk you through about putting pads on. Then we're going to do our chest compressions, depending on what the defib said. Obviously, listening to it, especially when that adrenaline is going, is quite important. So listen out for those prompts, just to make sure you're coming off the chest when you need to, because you don't want any movement on the patient. Chest compressions. The most important thing for me going into cardiac arrests is whoever's there first, whether it is me or whether it's a bystander, will always generally be going too quickly. The adrenaline's rushing. you want to do your best, but the importance is to be calm. And thankfully, on most AEDs, you have a little button that gives you like a metronome or a counter, because nice, slow and effective compressions are really, really important, rather than just going to town on the chest. We want to make sure they're at the right rate, and we want to make sure that we are coming off the chest to allow the heart to fill up. Obviously, then we're going to use our breaths with our BVM, and we're going to do 30 to 2 with adults. So 30 compressions, 2 breaths, and then listen to the AED going through those 2-minute cycles. And if there are bystanders, if there are people willing to help, that can free you up to use your airway adjuncts, etc. Now, pediatric resus is a little bit different, but the basics are the same. So we're still checking for the young responsiveness. We are still making sure we know that the airway is open and it's clear, they are breathing, they are not breathing. But then we are going to do rescue breaths. The rescue breaths are there to combat a respiratory arrest. And we know with children, generally speaking, it's going to be oxygen or airway related. So we do those initial rescue breaths, and then we recheck for those signs of life. And then we follow the same protocol in terms of getting the AED on, listening to those voice prompts. And then we're going to do 15 chest compressions rather than the 30. Still doing 2 breaths because the priority is oxygenation with young bodies. And then we're going to do 15 to 2. Now, in terms of the scope of practice, that's where the basics and the most important bits finish. There are lots of other things that you're going to see tonight that it is really useful to understand and to know what's going to happen, so that you can assist, you can get this bag, that bag, and also so that you're not surprised when it happens. I think sometimes, especially for family members, and it may be that you've turned up first on scene, you've initially asked the questions to the family member or loved one or bystanders, and you may have built up a bit of a rapport. So knowing what sort of thing might happen is really useful to be able to explain to them, because as crews, we dive in and we do an awful lot and we forget that there is somebody watching this potentially traumatic scenario happen to their family member. So understanding what's going to happen here tonight is really important, but it's also important to know that that's not what you're doing. And thankfully, you don't have to worry about the many, protocols that we go through when we're thinking about what we're doing with drugs and with needles and airways and all sorts of things. But like I say, it's really useful to see it. It's just to be clear that that's way out of scope for CFRs and volunteers. But it doesn't mean you can't help and you can't support us in providing those treatments towards the patient. So I will pass back to Liz.
Thank you very much.
She knows exactly what's going on. Thank you very much.
Thank you. Thank you very much, Mike. So the next person that I'm going to welcome to the stage, who has very kindly probably orchestrated all of the clinical people that are here this evening. All the clinical staff are here thanks to Luke. Now, Luke Roberts, Andrew, and you probably saw me sat in the background asking Emily how I said, yeah, you've got the whole thing. So Luke is our regional cardiac lead, and he's been kind enough to come along this evening and talk about effectively what is going to be happening when we're looking at the additional scenario. But I think, Luke, if I hand over to you, and he's going to talk a bit about a few statistics as well, which would be really good. So thank you, Luke.
Thank you. Just a massive thank you again to Liz. I think you'll get them throughout the evening, because to see this many of you when you've probably been at work already or been doing other things to come here and take part in this, as well as what you do with your communities, is fantastic. So thank you to Liz, but also to all of you for everything you do. So my role, as Liz said, is looking at how regionally we can support the cardiac patients, which obviously includes those patients that you go to that are in cardiac arrest. I just want to go through a whistle-stop tour of some of the statistics and the data to show how important your role is, both within local communities, but also when we expand that out to the east of England, how much of a difference you make. So, could you have the next slide, please? So this is looking at the data from the last year, so from September to August, from 2022, 2023. I've picked this because there's a lot more published data from before that, but something called COVID happened and that skewed a lot of our numbers. So we're going to use this data because it probably represents more where we were before COVID. So during that year, so that 12-month period, we were called out to just over 6,300 cardiac arrests. Of those people, we treated just under 2,000. And that number might not be what you're expecting. But as we learn more about anticipating a good death, making sure patients that are palliative or an end-of-life pathway are able to have their wishes supported and die in the place that they want to, we're going to go to more and more patients that we recognise that dying process and we don't start that cardiac arrest. And that's the rationale behind the number of those patients that we will have gone to, and we would have recognised that actually they're at the point where we weren't able to provide clinical support, and that's when we give that psychological support to the family and the relatives. So of the 1,882 patients that we treated in the east of England for cardiac arrest, we attained a return of spontaneous circulation in 982. Which is a fantastic number. That is 982 people that went into cardiac arrest that without bystander CPR, early intervention, early calls for help, early defibrillation, wouldn't have been able to have a return of spontaneous circulation. Now we know those patients that have obtained a return of spontaneous circulation, or a ROSC, we'll call it, because I can't say it all, they are the sickest that they've been. We know that they didn't go into cardiac arrest for no reason, and there's an underlying reason that we now need to treat. So we're not always going to be able to maintain all of those patients. Some of them will have had devastating impacts to their heart from heart attacks, maybe injuries that have then put them into cardiac arrest. So we're not always going to be able to save all of them. And during that year process, we had 288 patients out of the 1,882 that survived a discharge, went home to their families and were able to undertake some kind of meaningful quality of life with their families, which I think we should just pause for a moment and just look at that number, because you all had an impact. If you've done at least 1 hour or been to one patient in the last year as a CFR, you've influenced that number at the bottom of patients that have returned home. So I think you should just give yourself a round of applause for that. And we'll have the next slide. And just looking at that for yourselves. So looking at the number of patients that went into cardiac arrest that were treated, you were allocated across the region. And I know there's hundreds of pockets of CFR groups. We work quite closely with the ones in Hertfordshire. Anyone from Hertfordshire here today? No. Okay. Right, Liz, next one. Doing in Hemel. Okay. Yes, please. So of that, we had 614 cardiac arrests that were attended by CFRs. And you arrived at 350 of those. We know some of them would have been stand downs because unfortunately they would have fitted into that category of not being, of having clinical treatment, or that actually we were able to get a lot of resources there quickly and we didn't need the additional resources at that point. And you were first on scene at 188 of those cardiac arrests. And that's where we come back to that. I know we call it basic life support, but I think we should get rid of that and just call it essential life support, because there's nothing basic about it. Without it, nothing else that comes after it is likely to be meaningful. So to deliver that that oxygenation, that early defibrillation, and that CPR to keep that some of that that pulse going, that's what's making a meaningful difference. And I think that's going to be touched on later by Nick and Emily when we talk about that chain of survival. You can have the next slide. So I just want to ask some quick questions, just to make sure everyone's on the edge of their seat for when they go into the next presentation. And I was going to ask the questions, but I've realised that the way the slide's been put up, it's actually got the answers. So, right answers only. 78% of cardiac arrests occur in the place of residence, so at home. So I think the reason for putting this up is to think about the impact that you can have in your local communities. So if you're at home and you book on because you're working from home and you're able to go to that person, hands up if you live more than 10 minutes away from an ambulance station. Okay, and hands up if you live more than 10 minutes away from a hospital. Okay, so all of those hands are likely to be somewhere where if you go to a cardiac arrest, you will probably arrive before an ambulance, because they're likely to either probably come from where they've started or from the hospital. That's not always the case, but we just need to think about the impact you will have in those 78% of your neighbours, of your friends, of the people you live nearby. So 72% of cardiac arrest patients receive bystander CPR, which is okay, I think, until we compare it to other places. If we look at, say, Sweden, places where we have it in the primary curriculum, if you want to go and get your driver's license, you have to go and do some CPR training. Scotland, some really good initiatives about getting everyone CPR trained. If you have a cardiac arrest here, you're more likely to have bystander CPR if someone witnesses it and they know you. You're more likely to have bystander CPR if you're a male, and you're more likely to have bystander CPR if you're known to the person that finds you. All of those things that can have that chance difference as to whether you're going to get CPR, our responsibility really is to make sure everyone in the community knows how to do it, and that we know how to call them to the right place if we're able to deliver it. And 21% of patients, or just over, were in an initial shockable rhythm when they were found. So I'd probably challenge that and say if we got there earlier, it would be higher. So we need to think about when someone goes into cardiac arrest, those initial phases of cardiac arrest, it's just like turning your car off if it's an electrical problem. If you can turn it back on early enough, if you can defibrillate it back into a normal rhythm and get that electric started again, we've got a good chance of potentially being able to do something with that heart. If you carry on just pumping that, and everyone's probably flooded an engine if they're old enough to have a car that we just keep doing that and pumping the pedal, that's essentially what's happening to the heart if we let it go past about 8 minutes, where we start to see all of the blood slowly start to slow down, not move. We see the heart start to swell. All of the vessels start to get a bit leaky. So we've now got an engine problem as well as an electrical problem. So it's a lot harder to start that engine. And if we do start it, we've got to do a lot more work. And if we keep doing it and we're not getting anything from it and we go past kind of 10, 12 minutes, we've got to the point where metabolically, so all of the cells that help us to start that heart again and to get the oxygen, just aren't in a position where we're normally able to save them. And that's why it's crucial that we get yourselves, bystanders, and our ambulance colleagues there within the first 8 minutes of a cardiac arrest to be able to deliver that defibrillation. Next slide, please. So, has everyone seen this? Yes. Has anyone not seen this? Fantastic. Okay, good. So I just want to highlight, there's a better graphic of this, and I didn't have time to put it in, and that's where the first two bubbles are twice the size of the last two, because the importance needs to be on the essentials that you're bringing. If we can't achieve those, then as much clinical quality, expertise and teamwork we can bring later down the line, it's not going to have an effect on that heart that's now swollen. So just have a think about the impact you have on this chain of survival, but also throughout. Part of tonight and what we've tried to work hard with Liz is that you can see the impact that a CFR can have throughout the cardiac arrest. Yes, it's fantastic to get you there early, get you doing CPR and get defibrillation, but when you arrive, you're part of that team. There's no person that is more important or less important. Obviously, the patient is the most important person there, and the team around them are the ones that need to work together. So hopefully from today, you can see what the bits of kit are that you'd be able to assist us with, to show us, to be able to help us to get. But also, we're going to talk a little bit in a minute about non-technical skills. So things that aren't a scope of practice, but are just how we communicate with each other, how we work together, that anyone can do, that makes it a bit easier to hopefully help the patient. So I think that's it for slides. Perfect. So I'm going to hand you back to Liz. I just want to say thank you again for everything you do. I hope you enjoy this evening. And have a good night.
Thank you, Luke. This kind of goes back to why I love this, because we get to hear from people that are, experienced in their field, and I think it's amazing. So thank you, Luke. Honestly, it kind of puts it into perspective again, which is really nice. So I'm now going to welcome, and I'm going to try, Emily Legallion. Yes, Emily, who is our new resus officer for Essex and Hertfordshire and West Essex, thank you. And Nicholas Williams, who is our urgent care paramedic as well. Did I get that right? Urgent? Yeah, okay, fabulous. So if I can welcome Nick and Emily to the stage, and they're going to take us through the next set of slides to discuss kind of the other bits and pieces that Luke was covering off as well. So please welcome to the stage. Thank you.
Hello, good evening, everyone. Can you hear me okay? Yeah, is that okay?
Yeah.
Good. So thank you, Liz. I'm going to echo what everyone else says. Thank you so much, all of you, for being here, either in person or online. It's really important that we as clinicians can connect with you as well, because your role is so important. And I, for one, am very, very grateful for everything that you do for the Trust. So thank you very much. And thank you to Liz for putting it all together. Our slide set is going to be talking you through those essential skills for cardiac arrest. Nick's going to talk to you about the technical skills, those things that you're really, really good at, really good high quality CPR. And then I'm going to talk to you about the things that we can all do together, those non-technical skills. So I'll hand over to Nick.
Evening all. So the benefit of tonight for me is that I look around the room and I know Neil from Felixstowe, Mike from Stowe Market, and Paul from Leiston. So 3 massive areas in my patch, all 3 points of the triangle, and you're all here. So that's amazing for what we do here. So if we just go for the slides. So go for it. So when we talk about quality CPR, the thing that we need to do is get pressure into the heart. We need to have a good rhythmic compression rate. And when we talk about early defibrillation, it's imperative that we look at defibrillating the left ventricle. So the pad placement is crucial and key to this. So we'll talk about pediatrics on the right-hand side. So we have this AP, anterior and posterior position. And for an adult, you're looking at the right-hand side under the clavicle and left-hand side into the armpit, really. So you can go straight across that. There are times in a CPR or an arrest situation where you can't get access to the chest, and you have to just make amends as best you can, whether you can't move the patient because of environmental factors or the patient's body mass size. You can't physically get to them on your own, and a lot of our teams respond as solo. So as best you can to get some early defibrillation and some early chest compressions is essential there. So we know that you can do iGels, is that correct? No? No. Okay. So just OPs and BVMs. Okay. So, which is great for a pediatric, because what's the primary cause of an arrest in a child is normally hypoxia secondary to choking and bits and bobs. In an adult, so as Luke alluded to beforehand, a lot of our patients, we're doing CPR for the last organ that's working rather than the first organ. So we go back into the 60s and 70s when they introduced CPR. It's for people having heart attack surgery on a table who went into a VF or VT rhythm and were shocked and then were defibrillated. We go back 40, 50 years now, and people who are surviving longer in life with comorbidities and polypharmacies, it's often the last organ that dies. And we talked a little bit about futility, about our arrests and why we shouldn't be doing CPR on a lot of these patients who you will be stood down for on the route there. But a lot of times it's about trying to get the early doors, good quality CPR and an early defibrillation. Okay, next slide, please. So airway is key. Airway is how we're going to ventilate and put oxygen into our patient. So it's very, very important that we manage the patient in a way that we can either jaw thrust or manage the head tilt chin lift to get oxygen into the lungs. And we have OPs and BVMs to support that. And when crews turn up, we will have advanced airways, whether it is an iGel from us or an intubation tube from a CCP. We talk about padding the shoulders for children to try and keep neutral alignment. Equally, with a rather large patient who's got a big chest, you look at trying to get the earlobe in line with the chest to make sure that their body is in line, so that if you tilt the head backwards, you can get a good air entry. If you're trying to ventilate and there's no movement there, you can try and pad the shoulders and allow them to get a better alignment. Next slide. So for those who have been backed up by a trust crew, or you've been there after the crew have got there and you've come as a secondary person, are you all aware of what we carry and the kit bags that we have? Show of hands. Everyone who's happy, hands up. Okay, excellent. So for those who aren't sure or aren't a fave with the kit, what bits kind of throw you off a little bit? Be free to speak up. Lots of whispering. So everyone's happy with the airway module. So which bag would we get for? Would we ask for our adult airway? The blue one, perfect. And if it was after some cannulation, what bag would it be? The red bag. Okay. The long red bag or the little square bag? Little square one. Yeah. Because that's the thing. So we talk about these human factors. When it's very, very busy or it's dark and you're outside and you call for a bag, I've often been guilty of not being clear with my instructions. Pass me the yellow thing when I want suction and someone brings me a drug bag. And then we turn up on scene and there's 3 drugs bag and no suction. It's having that clarity of things, like stopping yourself. And we're talking a little bit about human factors when you're I don't like the word bandwidth, but when your bandwidth is crazy and you've got so many things going on, you've got a loved one who's distressed, you've got a patient in cardiac arrest, you've got a crewmate who's may have been to a traumatic job recently, or a new CFR as your shadow tonight, and it's all going wrong, and you just need to have some clarity. So stop, have a little check around and say, can you pass me the bag that says adult on the blue bag, and just be clear and concise with that. Okay, next slide. Yeah, so we'll briefly talk about what we call the pit stop scenario. So if you ever watched the Formula One, where the car races in 100 miles an hour, stops on a sixpence, and 6 people attack it in less than 9 seconds and whizzes off again. We're not expecting you to do that, but we expect to have a little bit of understanding about what part of our crew does what when we arrive on scene.
Just going back to the equipment, if any of you do want to familiarise yourself a little bit more with what bags you would find what equipment in, then we will have stuff available in the breaks to have a little look through. Okay. In terms of what our clinicians bring, we obviously bring all of this kit, and that's great, but we can also bring these non-technical skills. One of the things that we're really trying to drive at the minute is this pit stop approach. It's been around for a while, but can any of you put your hand up and tell me how often you've seen this happen at a cardiac arrest, where everyone's gone into that perfectly orchestrated role? Every time? No, we're not as good at it as we would like to be, and we recognise that we do need to be better. And that is part of my role. My role is a new role within the trust. There's 6 of us within my team, and we're hopefully going to start improving the teaching around cardiac arrest and making sure that we are giving our patients the best possible chance. One of the ways of doing that is the pit stop approach. So each person has a designated role. They don't deviate from that role unless they really need to. Yes, we can then become a bit task focused, but we have a team leader to bring us back. And they've got that good global overview, situational awareness. And you might have seen the adult cardiac arrest checklists that we sometimes carry, and they're a really good resource for that team leader to use. You can take on a number of the roles within this pit stop approach. Obviously, most of you are responding alone. I don't know, do any of you respond as a pair ever? A few of you, yeah. So you might have your own little way of working, like an ambulance crew has its own little way of working, and one person naturally does the chest compressions more and the other person naturally manages the airway a little bit more, but that's where we can play to each other's strengths and weaknesses. And there's no reason why you cannot take on a variety of these roles within this pit stop approach with the guidance of a crew. Okay, next slide, please. So Nick touched on those human factors. We've got things like clinical decision making, which you might be aware of, paramedic colleagues, technician colleagues that have come in and they might have made a decision that maybe you wonder where that came from. They've not verbalised it to you. It might seem like it's completely different to the last arrest you went to. That was a very similar arrest, but the decision making is different. That's the beauty of our job. We are autonomous. We all make similar decisions, but we might get to it in a different way. Decision making is one aspect that can be affected when we're overwhelmed on a cardiac arrest. Okay, and that's where things like communication, teamwork, and leadership, having a good, strong clinical team leader within that quite often is the manager that arrives on scene, the LOM, but it doesn't have to be. It doesn't have to be the most senior clinician. It's just whoever is most effective within that role, whoever can hold the checklist and have a good situational awareness of what's going on, not like the man diving with the shark behind him. That's what we want to avoid. We obviously go in, we think of danger, but sometimes we're not very good at continually worrying about what we're doing wrong. We think about danger, we forget about danger. That's okay. But what else? What other dangers are we coming up against? Is it our own practice that maybe isn't as effective? Task management, again, that links into those roles. We're going to become task focused. That means that we'll do that task really well, but we've got that team leader to make sure that we're all working in harmony together. Okay, next slide. So with a role, understanding what that role entails is important. Making sure that we're not trying to do lots of things at once. Initially, we're trying to do lots of things at once when we're on our own, but once we've got a team there, we need to stick to one task and do that one task really, really well. Prioritising things like you would when you go in and you stick the pads on, you've prioritised that early defibrillation. You know that once you've started chest compressions, you can't stick the pads on because you're stuck. So it's that same prioritising throughout the whole cardiac arrest. Using cognitive aids, we said about checklists. You're used to metronomes, hopefully some of you. And have any of you used the puck on the core pulse for a feedback device? I know some AEDs do have feedback devices, but you all carry very different AEDs, as I understand. So what you have available might be different. On all of our trust defibs, we have the feedback device, and we've also got some mannequins at the back for you to practice on this evening. And that has a similar kind of feedback device. It's going to give you information on your recoil of your chest compressions, your rate, your depth, just to make sure that everything we're doing is really effective. And then lastly, and arguably most importantly, is communication. As Nick said, it's very easy when we're stressed to say, get the yellow pouch, get that thing over there, you do that. We need to use names. Hopefully when you're in these rural communities, you might know each other's names and you might see a similar crew, but actually we know crews end up everywhere. And how often do you see a crew you've never seen before? They might not introduce themselves to you, but they should. And we really need to get better at that practice of using names and ensuring that each person knows who we're referring to and what kit we're referring to as well. So that effective closed loop communication, repeating things back, making sure that we're really understanding each other. Next slide, please. And then lastly, what I'd like to talk about is debrief. Have any of you been involved in a debrief after a cardiac arrest? Yeah. How many of you haven't? Just out of interest, just raise your hands. Still quite a few of you. Okay. Debrief is really important for a number of reasons. A debrief is good for learning. We can understand what went wrong, what went really well, what we need to improve for next time. But it's also a good way of flagging up any welfare issues. And particularly as volunteers, we want to look after you. You do a great job. We don't want you to decide that you don't want to do it anymore. Have any of you been referred for trims before? Do you know what a trim is? Yeah, a few hands. Yeah. So that's, again, a trauma risk management assessment, just so that we can really look after you and make sure we can signpost you to things. So you have access to all of these things through the trust. And debrief is a really important way of getting those things to you. If the patient has gone to hospital, sometimes it's difficult then to be involved in a debrief, but hopefully what we're going to work towards is more of a cold debrief model. So a hot debrief happens straight after the call. If we've had a role on scene, then you'll be involved in that, hopefully. If we've gone to hospital, that's a bit harder. So we'll look to do a cold debrief a few days or weeks later. And if we can get you guys involved with that, it would be really great. So do keep your eyes out for that. Has anyone got any questions? Because we do have a little bit of time for some questions. So that's whether that's aimed towards myself, Nick, Luke, anything that we've spoken about from a clinical point of view.
Nothing.
Stunned silence. Yeah, go for it.
Just one thing for me. If you ever feel that you need a debrief after a job and the crew are still there, please feel empowered to ask the question. I know some of us are in blue, some of us are in green, but we're all here for the same purpose. So if you're on scene and you've been to a job and it's not quite gone right, and the crew is still there, please ask. A lot of you in the room know me, and I'm quite loud and boisterous, and quite happy to have a discussion about anything with anyone. So please feel free to ask the question. If it was something that you've not been to before, it may have been not quite like you said on the tin. It may have been a traumatic arrest, and you only find out when you arrive there, and it's got you a little bit. Please speak to us. Whether or not you speak to people at home or your CFR teams, please feel free to ask the question on scene. And there's no daft question. There's daft people in green, but there's no daft questions. So please feel free to share those.
Is there any questions? Or someone be brave, because we've given loads of time. No one. Mike, have you got a question? Mike, you got a question?
Anyone online got any questions?
Paul, ask a question. Paul.
Yes, at the back. At the very back, I see a hand raised.
Yes, I'll ask a question. Obviously, I know the answer, but I'll ask it.
Excellent.
We have the adult and paediatric,
Yes.
and obviously there's a distinction between what is adult and what is paediatric, both in terms, and if I remember correctly, it's different. The ratios, the cut-off between adult and paediatric is age-wise.
The cut-off of compression rates.
Yeah, well, yeah, there's 15 to 2.
Okay.
There's also the DFIT, and if I remember correctly, it's not the same age.
It depends on which. So different devices will have different jaw rates.
Just repeat, can you just really briefly, because the people online aren't going to hear that question. Just
Okay.
Very briefly.
So there's a question about both the shock rates and the compression rates of children and the age bands. Is that correct?
Yeah, it's the cut-off between
The cut-off point.
pediatric, both in terms of the 15 to 2.
Okay.
And the pediatric part and the adult part.
Yeah, very, very good question, because sometimes you can get a 14-year-old who's 6'4", or you can have a 17-year-old who's 5'2". It's in terms of age banding, adult drug dosages start at 12. So a child is normally up to 11 years old, and then an adult starts at 12. So that allows us to work out shock jaws and drug dosages. So as a generic rule, adults start around 12. So 15 to 2 is from 1 year, or from birth to 11, essentially. And then you have your neonate resus, which hopefully you will never go to, which is a 3 to 1. Okay. Does that answer your question?
Yeah, and is it but is it the same for both? Is it the same cut-off age? Is that the same for both and for the pads as well?
No.
It depends on the. Yeah, I'll check with my resus officer. I'm the urgent care guy.
Most AEDs that have a child mode, that delivers a 50 joule shock, and that is ideal up to the age of 8.
Yeah.
So
That's what I thought was a different name.
yes. So Nick's quite correct in what he's saying about the adult dosages and everything changes at 12. What can get a little bit confusing, and what I don't want you to worry too much about, because actually, as long as you are performing good high quality CPR, whether you're doing paediatric or adult, if you waste time worrying what age this person is, I'd rather you do something. In terms of what the Resus Council recommend, which is obviously my Bible, then that is up to the age of 18 for paediatrics. The reason for that is because the cause of cardiac arrest in a 17-year-old is most likely to be similar to that of the cause of a child than it is to the cause of an adult. So that's the reasoning behind it. However, if you go in and I think I've chatted too much.
No, you're good.
Okay. If you go in and you don't know the age of this person, because that happens quite often when they're young, people are panicked on scene. We don't often get the age correct sometimes over the phone. As long as you estimate their age and do what you think is right, that's all I want you to take away from it. But the reason that it is up to that age of 18 is because of that cause of arrest. Okay, and that's what we're doing. When we're doing paediatric BLS, we're focusing on those breaths. They're more important because it's more likely to be respiratory driven But when we're an adult, we know it's more likely to be cardiac. That's why there's not so much of an emphasis on the breaths. Does that answer your question? Yeah. Fabulous. Okay.
David.
Oh, yes. Hello.
So the thing I always wonder about a bit is when you arrive and when you're going to start your BLS, the time it takes to put in OPA feels like quite a long time. And so I'm always slightly conflicted. Do I just go straight in with the BVM, do that, and wait until 2 minutes for a rhythm check before I get the OPA out? How should I prioritise that? Or should I be going with it straight away? What's your...
Yeah, so I'll just briefly repeat David's question for everyone online. It was just about how you would prioritise tasks with inserting an oropharyngeal airway and getting your BVM out, whether you're wasting time trying to put in an oropharyngeal airway. So if you consider what that airway adjunct is doing for you, it's going to make your ventilation slightly easier because it's pulling that tongue away. So there is benefit to taking that time to doing it because you're on your own, and it's quite difficult to manage an airway on your own. Even we recognise as clinicians, we're not always very good at managing an airway alone. So everything you can do to help that by putting an oropharyngeal airway in is only going to be a good thing. I agree with you. It feels like forever. Everything on a cardiac arrest feels like it goes forever, and then you look and you think, oh, actually we were only there for 2 minutes on our own, but it feels like you're there forever on your own. So I think that you absolutely should use the time to put it in, but I don't know if Nick thinks any differently.
I suppose if you need to put an adjunct in and you can't adequately ventilate the patient, then you need to take time, because we always talk about airway being king. So if you can't ventilate your patient effectively, then you need to take time to put an OP in. But if you're managing them with just a simple face mask and a BVM and you're getting a good rise and fall of the chest, in my mind, CPR and defibrillation is going to get a ROSC in this patient, not necessarily airway management, unless it's been a drowning or any kind of anaphylactic type thing. If it's a simple cardiac source and that patient needs quality CPR and defibrillation, if you're getting a good rise and fall with a BVM and a face mask, I wouldn't waste time with the OP. As you say, if it's taking time to size and you've got the wrong size, you get the next green one out, wrong size orange one out. If you're wasting a few moments of time and you're not allowing the pressure to remain high to give you a chance of getting that spark into a VT or VF so we can defibrillate it, and you're letting the pressure drop down in the heart, then it's a difficult thing to answer in a scenario, unless you've got a patient who has got a difficult airway to manage, and that is a priority. However, if you've got good ventilation, good rise and fall, I would stick to CPR, chest compressions and ventilations without the need to change an OP. But again, every patient is different.
Every situation.
And people who've got no teeth, elderly people whose teeth fall out, are sometimes difficult to manage, even though their oral cavities is huge. You think I should get a good seal here, but it's difficult. So every case is a case by case thing. But all I can say is manage the best you can. If you need to manage the airway, then that is your priority. If you don't need to manage the airway, then prioritise your quality CPR.
Cool. We've got a question online from me. That's all right. So I don't know who's going to answer this. We've been given a question online from Tony, and it says, "Can we cover what is peri-arrest, please?"
Yeah.
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 Go for it.
Hello. This actually happens quite a lot because you probably hear people talking about it and their peri-arrest. It's not anything to do with Nando's, I promise. Sounds like it is, it's not. It's that patient that's really at risk of cardiac arrest. So anyone that is significantly unwell due to shock, that might be that they're an anaphylaxis and that we're worried that their heart's going to stop because of that, because of the breathing. It might be that this is a MI patient that is really, really unstable. We're noticing that their heart rate's dropping, their blood pressure's dropping. And we know that we're getting into that stage where if we don't correct it, this patient will go into cardiac arrest. So Peri-arrest is a broad term that is just used for that group of patients, and it could be coming from whatever that cause of peri-arrest is. But it's a term that we use to say, okay, this person's big sick and we need to do something. And if we don't get them to the right place quickly, then they are going to go into cardiac arrest. Does that make sense?
Awesome.
Yeah.
We've got another one.
Go on.
Brace yourself. So we have another one from David Hammond online. It's quite a good question. And I think probably a lot of you in the room might agree with this question. I know I speak often with Steve about this when we teach courses. And the question is, if I have started CPR and the patient is elderly or frail and the family want me to stop, how do I handle that situation? Hold it.
Ooh, what a question. So we often talk about futility and burdensome when we talk about CPR. Now, I've mentioned before the concept that CPR and defibrillation is for the first organ that dies. So by the time an elderly patient who has got kidney disease, lung disease, they've got heart failure, by the time that their heart has finally stopped, the chance of getting a quantifiable return of circulation to a point where that patient will walk out of hospital is very, very slim. We know that. Our chance of success in an out-of-hospital cardiac arrest is sometimes less than 1%. So it's a very difficult question to ask when you're, as clinicians, we can walk into scene and our JL count will support the fact that if someone has got a polypharmacy, so multiple medications and multiple comorbidities, so long-standing physical problems, that we can look at that patient and say that their quality of life will not be restored by doing this CPR. And that's a clinician type thing. So when we go to these patients, and I'm a great advocate for end-of-life care, and I'll do my very best to offer the best care I can for someone in the last days to weeks of their life. But when I look at a patient and you look around the room, you get this global overview as you walk into every scene. You look for your dangers, your responses. I look at soft signs. I look at the hospital bed. I look for the catheter attached to the patient. I look for the ramp at the front door. I look for the multiple care folders in the care home. I look at the fact that they're probably on 40-sip drinks because they're not eating very well. I look at their body mass, that they're very frail and they've got poor mouth hygiene because they're not eating and drinking for weeks. And then you look at this patient and say, what would I want for my loved ones? Would I want that for me or my loved ones? And the answer is often no. So from a clinician's point of view, we have got the autonomy to look at the best interest in that outcome. And if the outcome is going to be very, very poor for that patient, so someone is very frail and elderly, but is talking and walking around, they have a cardiac arrest, we bring them back to life in a non-talking vegetative state. That's not a good outcome. So we talk about futility and burdensome. So it's not just burdensome on the patient or the crew, it's the family and the wider healthcare. So if we're going to create a patient who's going to be so impaired by that action, then starting CPR is probably the worst thing we could do. And that's an ethical decision that you need to have with yourself. And I know that we have access to CAL for all you guys, and it's very difficult when you're in an active CPR to stop and have a phone call under your chin whilst doing CPR. I get that, but I've been there as a solo RRV, and you're phoning a friend to get advice whilst doing CPR, saying, I know this is wrong, but I can't stop because there's no DNR. There's no advanced care plan. There's no respect form. And everyone is saying, save them. But you look at your patient who's 96 and you think at some point it's no longer a cardiac arrest. That patient's passed away. And I think that's kind of what I think on that. And I pass on to my colleague for any other impact on that. But it's a very challenging thing, isn't it, when you're discussing, should I be continuing this?
I think if we just clarify really quickly.
Yeah.
Mike.
I was just going to jump in for scope
Yeah.
for the CFR,
Yeah.
if that's all right. So, just in terms of obviously CFR scope, which is my bag, if you've gone to a patient that's in cardiac arrest, there's no DNR, there's no signs that are unequivocally associated with death. So they're not in rigor mortis, they've not lost a very important body part, for example, the head. You are going to start CPR. If the family are telling you not to and you feel you're in danger and that they're physically going to stop you doing it, then that's absolutely acceptable to withdraw. But I think it's quite important to explain that you are a volunteer, you're not a medical clinician, not a healthcare professional. You are doing your best for this person, and then decision makers can take what Nick's sort of talk about, and they can make that decision. So if you have gone to somewhere and you have started CPR, there's nothing that's telling you not to from your scope of practice. Continue CPR unless you feel you're in danger, but just trying to explain why you're doing what you're doing. And yes, it's not nice, but it is important that you continue to do that until somebody with more clinical experience can make that global decision. So I think that makes it clearer for the CPD.
It makes perfect sense. And I think that's why this makes a lot of sense to have us all here, because many times I've been stood in a room and just gone, and I know there's people here that I've gone on shifts with who I'm looking at you, Catherine, and we've gone to shifts and I've just gone, oh my God, I don't know what I'm doing, and I'm panicking, and I don't cope well with it, and something's happened. And I'll put my hands up and I'll be perfectly honest with you. The reason I know Nick is because Nick did my trim referral 7 or 8 years ago, and that's how I know Nick. Now, it wasn't a cardiac arrest, it wasn't, it was unequivocal signs of life extinct. And in hindsight, I probably should have done things slightly differently. It was a learning experience. But I think the bonus with having resus officer and quite a senior paramedic who knows what he's talking about, and the guys in the room, it gives us that real understanding of how we all link in together. And I think that's why it's key. And it all goes back to our chain of survival, I think it's fair to say. Yeah. I think we've got another question online that wanted answering. Which one are we on to, Phil? Yep, got it. It's all right. I can't see. What's in the kit bags? So they would really like to have a quick look at what's in the kit bags. So what's in the kit bags and a quick run through would be helpful. So if you stand here and bring an item and talk through that item, we would be able to do it with all of you seeing and the guys online seeing as well. So one of the things that you would be using would be fabulous. So who wants to talk and who wants to do show and tell? And I'll talk. I'll talk. So come
Generation game.
Nick is my glamorous assistant. Okay. So
You should have got some a bit more pretty. This is all you're getting.
I'm sorry for those of you online, because this isn't going to be the clearest of things.
You stand. Yep, you're good. Stay there, Nick.
I'm only 5'10".
So this is the adult airway module, and this is, I feel like I'm on a tele shopping thing. It's good, isn't it? For just $19.99.
In 15 instalments.
So this is the adult airway module. In here, you'll find your basic airway adjuncts that you'll be familiar with. So you've got your oropharyngeal airways of all adult sizes. We've also got a laryngoscope handle and a blade, which is what we'll use just to visualize someone's airway. We've also got some nasopharyngeal airways in there, which you might have seen inserted before. Nick's just put the light on the laryngoscope blade for you. And that's just a really nice way of visualizing someone's airway. So if we've gone to a choking or something like that, then we might get that out, and we might also use our forceps, which will be in there as well. Somewhere. I can see them just at the top there. There you go. And they're just basically a really long pair of tweezers, so that we can grab some bits out of someone's airway if we need to. We've got our bag valve mask in here, a variety of different size face masks, because obviously people come in different shapes and sizes. And we've also got things that we will add on to that eye gel once it's in situ. So like our catheter mount. And you might have heard us talking about our capnography or our end tidal CO2, which is a really good measurement for what kind of exchange of like metabolic things that we've got going on inside that patient as we're doing CPR. So it's a really good measure of both our airway and our chest compressions. Lovely. Okay, that's our adult airway. And then separately to that is our eye gel pouch, which I'm sure all of you have seen an eye gel in action. But it's just a really nice, simple airway that sits just above the glottis. So I'm trying to make this not sound too paramedic-y. It's a nice airway that we can put in, and it is a safe, advanced airway, but not as effective as a tube. So you might be familiar that we used to intubate. Now only a select few of clinicians will intubate now. This is good for most patients, but some patients will still need to be intubated. Once we've got this in, we can attach our catheter mount, our capnography, we can get a good reading back. And again, that comes in different shapes and sizes based on the weight of our patient. What else have we got? So also this is again within that main grab bag, that main response bag. We've got a variety of oxygen masks. We've got our
mini suction.
Oh yeah, our little mini like manual suction, which is handy as well. And we'll also show you our suction, our main suction unit as well, which I'm sure you're familiar with. And then you've got your variety of suction catheters on the side of that. Lovely. Also within that same bag, we've got a paediatric module and a oxygen cylinder. So that's that bag that you see brought into most calls that we go to, because it's got most of our basics in. And then in the front of that bag, Nick is just going to grab some other bits. So we've got like a diagnostics pouch, which will have a tympanic thermometer in it, and our BM kit, our glucometer, so that we can check their BM, and a nice little sharp spin in there as well. Now we've got the drugs bag. So all of our drugs are going to sit inside of here. Obviously in cardiac arrest, we're only thinking about a few of the drugs that are in this bag. One that gets used on most cardiac arrests is going to be our adrenaline, which are the little purple mini jets. And then we've got our amiodarone, which is going to be used for our shockable cardiac arrests. Also within that bag, we've got our oral medications. We've got some IM adrenaline, everything that's in an EpiPen. We've got our IV paracetamol. He's tried to pick it up, but it's going to collapse. It's not ideal, is it? We'll just have to come and see you in person.
We'll take some photos. So yeah, so we'll circulate some photos.
Great. We'll take some photos and we'll send that across to all of you. But your drugs bag has got everything in it. The only thing that it doesn't have additional bits of is fluids. So if we need like an extra bag of fluids, then we'll have to go and get the infusion pouch, which I don't think we've got one in here. But it's only got one bag though, hasn't it? Yeah, so it's got enough to get you going, but if we're on a cardiac arrest and someone says, can you go and get another bag of fluids? It's not in the drugs bag, it needs to be in a separate bag. So that is your basic bags that we've got. We've also got the cannulation kit and other Gucci bits inside this second bag, which Nick is just getting up. So cannulation kit should have enough in there for the average paramedic to get a cannula in.
I'm not too sure what that means.
You've got gauze in here, you've got K-bands, you've got razors if you need that for your patient if they're particularly hairy. All sizes of cannulas, three-way taps, needles, intramuscular needles, tourniquets, syringes of all sizes. Yep, it's got everything in there. And then also, if we've got an IO, just while we're on the topic of access. So some of you may have seen the Easy IO in action. It gets brought out on a lot of arrests, not all of them, but in that patient that's quite shut down and we can't get an IV line in. then we will use the Easy IO kit to get access through their bone. Something that can be quite traumatizing for people that aren't clinical is this is quite often referred to as the gun. Please don't call it that, it's a driver. If a relative hears, get the gun, that's what we want to avoid. So it's a driver, okay? And it's because it drives that needle into that person's bone, and then we can get access through their bone marrow. And it's just as effective as getting a cannula into their vein. So a great way of getting access, particularly in children, because we're not used to cannulating children. Yeah, really, really good bit of kit. What other little bits and pieces? Yeah, we've got a little dressings pouch as well. So we've got trauma dressings, which you might have come out and play. We've got things like cat tourniquets that we'll use for those catastrophic hemorrhages. We've got our special gauze and other dressings that are available, like pressure dressings that will provide a nice bit of pressure to that patient's wound. We've got some chest seals as well. And these kind of trauma jobs, I know that, can you get dispatched to traumatic cardiac arrest? No. So
Knowingly.
Okay.
Knowingly.
Okay.
Trauma.
Okay. Which is a very good point, actually, because sometimes a cardiac arrest may not come in as what it is. So it may come in that it's a bog standard cardiac arrest and you get there and it is traumatic. So that's where you'll see all these extra bits and pieces coming out.
And the last thing is just fluids.
Lovely. And then we've got a lovely bag of fluids. And
Some salty water.
giving sets in there as well. Lovely. So that's a bit of a whistle-stop tour to what we've got.
Yeah, I think we can
Yeah.
take pictures of.
Yeah.
Yeah.
Fabulous.
Any more questions?
Got one more.
Got one. Can we pause the one online? Is that all right?
The bags that sort of the crews are bringing, are they built by the MROs to a standard?
Yes.
Because
So
I've quite often sort of brought in sort of kits from crews and had cannula kits separate, dressing kits separate, and quite often, I mean, drugs bags, yes, they're standard, but
yeah.
the layout of the bags will depend a lot on what the MROs actually got available to them.
Yeah, so just for everyone online, that was a question about the standardisation of the kit, because some crews will carry it in the template it's meant to be carried in, and others may have it in a different area. So make ready is still quite a relatively new concept to most areas of the trust. I know certainly where I work, it's quite a new thing, and some crews don't like it. They'll pull everything out of the bags. That's okay, fine. But at the start of their shift, it should be in those modules. And hopefully, as we get more used to it, it will be more standardised. Obviously, I know some of you cover such a large area where you're rural and you might travel a bit more than other community first responders. You're going to see crews from different hubs, different stations. It is challenging. There isn't an easy way. We just need to, we're not very good with change. So we need to just get better. But hopefully in time, we're all going to be a bit more used to that standardised way of packaging all of our kit. It should be happening right now. We know it isn't, but hopefully we'll be getting better. But we recognise that that's hard for you guys. And that's where communication is really important.
Yes.
Yeah.
Thank you. I think we'll leave it. Yeah.
Lovely.
Yeah. Don't just.
Thank you.
Don't just.
Okay.
Big round of applause. Thank you. I know. So, huge thank you to Nick and Emily. I think what we're going to do is we're going to take a break. I'm going to say be really brave, okay? Because the guys have brought in some fab mannequins, the QCPR mannequins that actually are linked up to a projector over there. We've got a beautiful demonstration. I apologise to the people that are on So in the corridor, just behind you, you've got the guys from the flu clinic. Please go and see them. Bless them, they've travelled all this way. So thank you very much, and we'll see you shortly. Online, guys, online, if you can please come back at 19:35, and there will be a countdown for you as well. So we will see you in about 25 minutes, 20 minutes. Thank you. Okay, welcome back. We're back live again, so welcome back to the people online. Is everyone back in the room? Okay, nice and quiet then. So we're going to move on. This is the bit of the evening where I'm going to say to you, if you want to position yourselves, obviously the people online, I'll talk to you in a second, but people in the room, we're going to run a scenario shortly, okay? I'm going to introduce our next guest in a moment, but after our next guest has spoken, we're going to be running a scenario, okay? And when we've run this scenario, you might want to move yourself slightly forward so you can see. We're recording it. Obviously, it's streaming to the people online as well. To the people online, we are going to do our absolute best that we try and get every single camera angle, but obviously this is a bit of a practice, I think it's fair to say. So we're going to do our best to get every possible kind of angle for you. So with no further ado, I would like to welcome someone. I'm really pleased to say this as well, and he's travelled a really, really long way this evening, and that's David. So if David would like to come to the stage, and I'm going to let David introduce himself and let him tell you a bit about his story and why he's taken the time to come with us this evening. So, David, welcome. So, back to round of applause. So, right up.
Evening, everybody. I'm David. I've come from Cambridge, which isn't too far, but Liz was a bit worried when she invited me that it was too far for me to come. So obviously the game's been given away a little bit by the sort of subtitle under my thing here. That's all right, it's not a problem. I never read speeches out, but I'm going to start off just by reading something out that I wrote. I'm a farmer. Every year at the end, around about Christmas, I write an annual report of what's happened on the farm over the year. And my dad started it 40 years ago, and I sort of continued on doing it. At the beginning of the report, before I get into the boring stuff about our wheat yielded this and that or whatever, I'll write some sort of rubbish, a bit like Jeremy Clarkson when he does a car review, and 95% of it's talking about a holiday he had in Paris or whatever, and the last bit side of the car was all right. So the bit I wrote in my 2019 annual report was about when I had a cardiac arrest. So I'm just going to read that out. I suppose it's like an author coming to a thing and reading out some of his book, but I'm not selling you anything at the end. But I could do autographs if you want. So here we go. So I'll do this and then I'll go freestyle at the end of it. So I suppose that as a last day, it could have been much worse. With harvest having been rained off the previous day, Saturday, July 20th, found myself, Sabrina, Elise and Maddie heading off to London for a Perry harvest outing. Now, I should say, I thought, will anyone know what Perry harvest means? Because Perry is a word we use in farming, this bit, isn't it? I thought you guys won't know what Perry is, and we've just had an explanation of what Perry is. So that was quite serendipitous, really. Perry, just for the technical thing of people who are nerdy, you've got post and you've got pre. Perry is the bit that comes between post and pre, so that means what's happening right now. So that's the sort of etymological bit of it. Anyway, first stop in London was Kulu Kulu, a sushi conveyor place that I've been going to since I was a kid, and now my two love it as well. Next slide, please. That's my two up there. It wasn't a vintage visit though, as on the weekends there are a few people in there, so the food sometimes spends longer than ideal on the conveyor belt. My particular favourite thing they make is a prawn tempura and salmon tamaki roll, but it must be fresh, otherwise the tempura goes soggy and the whole thing goes tepid. On this occasion, I'd spied a few tired examples going round and round, so I ordered one directly from the waiter. Obviously, I thought, he'd know that this was my last meal, and a fresh tamaki would be dispatched straight away. I was wrong. He snuck over to the other side of the restaurant where he thought I couldn't see him, plucked a limp one from the conveyor and brought it over. Being a feeble Brit, I said thank you and averted my gaze. Next up was Milk Train, an ice cream shop in Covent Garden, selling absurd constructions that are way too sweet for me. In those pictures there, that's taken that day. They're way too sweet for me, and they'd never fit on top of the 58 pieces of sushi I'd just eaten anyway. But those without a Y chromosome seemed pretty happy to enjoy the sugar rush. Can I have the next slide, please? That's my wife eating her ice cream there. If I had to choose a last movie, it might have been Shawshank Redemption, or more likely The Big Lebowski. It would not have been Toy Story 4. Luckily, I managed to sleep through some of it, but no one was impressed, and it was a waste of an afternoon. At this point, the original plan had been to stay in London and drive back home the next day. For whatever reason, we decided that coming home would be easier, so that's what we did. Kids slept in the car, lifted them up to bed when we got home, easy life. What remained of the evening was boring. In fact, I think Sabrina and I had a silly argument about how to make a spherical cake, something neither of us had any experience with. I went to bed slightly irritated. I can clearly remember my next thought. This dream is incredibly vivid. More important, though, was my first sight. Like a duckling which imprints on the first thing it sees, I had a new mummy, and it was a clock. Or to be more precise, in the pitch black, it was a set of red numbers. Next slide, please. There we go. You can see I'm not used to turning pages. The red numbers kept on going up, sometimes in big chunks as I passed out again. Occasionally, I'd look down from the red numbers and wonder what the man sitting in my room next to me, typing on a computer, was doing. Why are you here all night with me? Isn't it boring? Don't you have a home to go to? At some point, after the red numbers had gone up some more, I asked where I was. You're at Royal Papworth. You've had a cardiac arrest, he said. I shut my eyes, and the next time I opened them, the red numbers were still there. Next slide, please. Since it was morning, the lights came on and the bustle started. Sorry, soon it was morning, the lights came on and the bustle started. One nurse came into my room. Isn't your wife amazing? She said. We only do 2 minutes of CPR at a time and then swap over. It's such hard work. She did 15 minutes on you all by herself. I grunted. My brain still wasn't fully switched on, but at least I still had the red numbers to keep me company. They knew how to keep me happy. By now I could see the red numbers was actually a clock that had a naff little wire coming out the side. I thought this was pretty incongruous amongst the fancy machinery everywhere. Surely the red numbers hadn't been an afterthought. Sabrina arrived in a dress with a big smile. I'm sorry I wasn't here when you woke up. Did you think I'd abandon you? She said. No, I only cared about the red numbers. Just stopped working again. Next slide, please. That night, it was morphine and not much sleep. The next day, doesn't really matter, the next side's not there. It's not that important anyway. Next day, it was time to go home. That's all right. That was enough pictures of my naked chest anyway. The next day, it was time to go home. I had 2 days of watching TV. But then it was August the 1st and the Aussie rate needed drilling. Everyone else was busy and I was bored of watching TV. What a testament it was that 11 days after I spent 15 minutes dead on my bedroom floor, I was back at work again, albeit slightly uncomfortably. There is now a picture of me driving a tractor. That bit. So you can imagine that. It's a picture of me with a tractor in the background. All I had to show for it was a large scar. I now found out that chicks don't actually dig scars, but also a very painful rib cage. Not many people can say that they've saved a life, although in here that's really not true. But my wife can, and I'm more grateful than I can express. There you go, there's me on the tractor. Over 90% of people who suffer a cardiac arrest out of hospital die, and many of those who don't die are left with brain damage due to lack of oxygen. That I survived totally intact for almost 20 minutes before my heart was restarted is incredible. I really am one of the very lucky ones. Thank God Sabrina had that big ice cream on Saturday afternoon to keep her energized. So there we go. That's the bit I wrote. When Liz asked me to come and speak, she initially said, we'll come and talk about what happened in your treatment and that sort of thing. Well, clearly I don't have any idea what it was because I went to bed and I woke up 2 days later. As far as I'm concerned, I do sometimes wonder, was it all a big prank? Was I like B.A. Baracus in the A-Team and someone just knocked me out to fly on an airplane and I woke up and they came up with this crazy story that I'd had a cardiac arrest and all this sort of stuff. No, I was a idiopathic cardiac arrest, so I had no symptoms at all. A bit like Christian Eriksen playing football, I just collapsed. Except the thing is, I was not in a football pitch surrounded by paramedics and 50,000 other people. I was at home. It was about 3 a.m. I was obviously incredibly lucky that I started presumably some sort of agonal breathing that woke my wife up. Luckily enough, she woke up, wondered what was going on, found me sitting up and then falling out of bed, collapsing on the floor. Clearly that could have, not happened. She could have woken up next to a dead body in the morning, which wouldn't have been much fun for her. Also, I spend a lot of my days alone in an office or in a track or whatever. So, so much of my life, I would have just been a body that was found. So, there's so many lucky things that happened to me all the way through. I remember afterwards, being told about it and my wife telling me how many people had been. I think so the first guy that arrived was a LOM from Addenbrooke's. I live about 10 to 15 minutes away from Addenbrooke's. There was a guy from Hart, because we live very close to the Hart station as well. But so in the end, I think there were 2 double crew ambulances, the LOM, 2 Harts, and Magpas came as well. And so, and I think there were some student paramedics too. So there was, 12, 15 people at the house. And myself and wife were discussing it. Oh, it must have been a quiet night. They bothered to send that many people. We all know actually that's fairly par for the course. Especially I was 37 at the time. Obviously they decided it's fairly high priority to send a bunch of people. Magpas came. One of the things I really, really enjoyed doing afterwards, have the next slide please, is meeting as many of the people I could who were involved, in the whole process with me. I see, I'm in various Facebook groups for cardiac arrest survivors and that sort of thing. A lot of the people who want to meet, paramedics, whatever, aren't able to do it. There's technically processes in place for that, and they often don't work. But it is something I really valued to do. This guy on the left, some of you here probably know him. He's called Greg Corns. He was the LOM, so he was the first person that arrived on scene. He got my ROSC. So my wife, I think, had been doing CPR for 13, 14 minutes. Greg came in. I was in VF at that point. He gave me a shock, but I didn't have a ROSC. So he then 2 minutes, and on second shock, I got ROSC at that point. So I was actually, without effective heartbeat for coming on 20 minutes by the time it happened. This was Greg, and Lucia's another lady. She was on one of the ambulances. I think she worked for a heart team in London now. But they came out to our house and met us. I met them again for the second time. Greg said, I didn't realize you were so tall. He's not very tall. It was quite amusing watching him and my wife having a competition as to who was the biggest hero, with both of them saying, no, you're the hero. And Greg said, no, you're the real hero, back and forth. So, I found that quite amusing. I've met some of the guys from Hart. I've met all the Magpas people. And, that's been a really good thing. I really relish that. The one bit I never wanted to get involved with, which I was offered, was, do you want to hear the recording of the 999 call? I like hearing everything at a remove. I don't want to be, put in that situation of hearing the stress at the time. It's a much more difficult situation for my wife, who, has had, I suppose, PTSD, which is fairly standard. She had to go through all. I didn't go through anything at all. So really, she should probably be the one standing here telling you guys what it's like. But yeah, they're the people you need to think about. I've been to quite a few cardiac arrests, and the bit that gets me emotional is seeing the reaction of people when generally it's not successful outcome. As we know, most of the time it isn't, unfortunately. So yeah, they're the people we really need to think about after everything's happened. Obviously, they're not the critical focus there. So yeah, I really enjoyed that. I can't quite remember now how I got pointed towards CFRing, because it wasn't something I knew of before. I don't know if someone mentioned it to me or whatever, but anyway, I thought, this is a great thing that I want to get involved in. There wasn't a CFR involved in my case, but I thought I'd like to do this. So I signed up. There's a local group to me. I say group. There was one at the time. There was one guy in it. He had two kit bags and one guy. So there was clearly a bit of capacity, for more people. So I joined up the next year, August 2020. So full COVID. I went and did my CFI course with Carl leading it, and Lyndon, who's down here, was also on that as well. So I did that and started becoming a CFR. I was very lucky. If you go to the next slide, totally, one of these freak things. On the exact year anniversary after I qualified or finished the CFR course, I was called out to a Code 9 in the next door village. And the parallels with my case were pretty striking. It was a Saturday afternoon. This guy, Darren, on the left, actually had a heart attack, was in cardiac arrest. I was first on scene. I'd managed to get ROSC. I think first ambulance arrived 3 or 4 minutes afterwards. That's taken about 3 weeks after that, I think. His wife had been doing CPR on him for 13 minutes or so. So it was really very similar to what happened to me. And I just thought, what a privilege that that's why I started becoming wanted to be CFR, is to help people who are in a similar position to me. And I thought, well, chance of me ever actually being able to do that is pretty slim. And so for it to happen after only a year, I thought, wow, that's amazing. And I'm so lucky for it. But one thing that really, that incident changed my perspective quite a lot, because, I'd said about how my wife and Greg had fought about who's the hero. Well, I'd always thought, well, Greg's the hero. He's the guy. He came, he did his thing with the pads, he got my heart restarted, everything like that. When I was that person, what I came to realize is actually, although I have the fraction of training of Greg or any other paramedic or whatever, I'm trained to come here and to do the thing I did. The person who's really the hero is the bystander, my wife, Sharon there. These guys haven't had any CPR training, anything at all. They're just thrust into this situation. They've called 999. They've said, right, start CPR, and they've just gone and done it. And, I've been to so many cardiac arrests now, and I'd say, I was looking at interest with the numbers about bystander CPR. In my experience, it's way less than 50% of people, things I turn up to and someone's doing CPR. And if they are, it doesn't tend to look like it's very good CPR. So these guys who spend, 10 minutes plus doing effective CPR to keep someone alive, they're actually the real heroes. It's not us, in blue, orange, green, whatever. It's those guys who are going totally out of their comfort zone to save someone's life, possibly someone they love. So if we go to the next slide, that incident then made me think, okay, really happy to be doing CFR stuff. Going to definitely continue that. But how can I help ordinary people to get better at CPR? So I was plugged in with MAGPAS through my involvement, being a patient, and they had started a community CPR training thing at the time. So I got involved with that, and I now provide CPR training to schools and companies, whoever it is that wants it, basically, because I do really think that is, that's the next frontier, or the super important thing that we need to get out there and do and promote and teach. So that's what I'm doing now, and that's my story, I suppose. So I'm very happy to take any questions if anyone has any.
Anybody got any questions for David? Pat?
I don't know whether you said it or not, but when you went to bed that night before your cardiac arrest, was it just like a normal going to bed? I know you said you had a bit of an argument or something, you went to bed, but had you any inkling that anything different was going to happen?
So the question was, before I went to bed, had I any inkling that there was anything going on? The very definitive answer is no. I said I had no argument. It was not, I know a blazing row or anything. It was some stupid thing about making a spherical birthday cake. No, there was absolutely no different to any other night at all. I know when Greg, the paramedic, turned up and, he's doing his stuff, but he's trying to get history as he's doing it. And he said to my wife, "What have you been doing today?" And she went, "We went to London. He had sushi." And, so he was wondering what was going on. And then I know she was a little bit, or when I came around, she was a bit offended that the consultants in the hospital, the cardiologist, had asked her if I did any recreational drugs, which answer was no. So no, there was absolutely no, no foretelling of anything at all. Totally idiopathic. We never found any cause behind it. The question I've asked, and no one ever would dare to give me a straight answer, is: given that there was nothing wrong with me, well, you can't prove a negative. Given that there was nothing wrong with me, after I'd had a ROSC, could they have just put me back to bed and I'd have woken up the next morning and gone, oh, my chest is killing me, and I'd have been absolutely fine, rather than spending a week in Papworth? I don't know. I should say I'm very proud of this as well. When MAGPAS came, they did all the stuff. They said you were very agitated, when you came round. And they said, yeah, this often happens with farmers, but we had to give you a triple dose of ketamine to So I like to think my ketamine tolerance is apparently very high. So I must be very manly.
Thank you. Anybody else have any other questions for David? Angie?
Do you have any sort of post-traumatic stress from being in ITU in Papworth?
Do I have any post-traumatic stress from being in the intensive care? No, I mean, definitely not specifically from the intensive care bit of it. I was pretty zoned out for several days after I woke up. I mean, I'd been in an induced coma, which I believe is, my sister's a doctor. She tells me it's, although you are not conscious, you're not sleeping. And so I basically gone several days without any sleep. And I remember sitting. So the first thing I remember were the red numbers. Apparently I had actually been conscious and speaking the previous day, 6 or 8 hours before, but that bit hasn't stuck in my memory. But I remember, the first 2 or 3 days, I literally just sat there. They gave me my phone, but I basically just sat in bed staring at the wall as my brain went round. I've been lucky enough to be fairly unimpacted by it. I occasionally have been through things where I have a nightmare about collapsing or something, and I felt it was my heart stopping. But I could count on one hand the number of those I've had in 4 years. So I think I'm quite lucky. Maybe it's naive, but the chance. What are the stats? I can't quite remember what it was. I think if you have an idiopathic cardiac arrest, you have something like a 25% chance of having another one within 5 years or something. I'm forgetting the stats now. There's a not insignificant chance I would have one again, because although it's idiopathic and they don't know what caused it, doesn't mean there wasn't a cause, just means they can't find out. So there may be something underlying. But as I haven't had anything, I'm not treated for anything, I'm not on any medication, have chosen, maybe not chosen makes it sound a bit strong. I don't worry about it happening again. I guess it's lucky that I've managed to be like that, because otherwise it'd be fairly unpleasant to be waiting for the sword of Damocles to drop the whole time.
Thank you. So I think from me, I want to give another round of applause to David for coming up today. So thank you. I think it's fair to say that that's pretty impactful for me. That made me kind of sit there and just, So I genuinely really appreciate David taking the time to come up and talk to us about that. And I think, thank you. Big heartfelt thank you, David. It was lovely of you. So brilliant. Moving on, I think what we're going to do now is something that we've never tried before. And it's going to go one of two ways. So brace yourselves. As you can probably tell, in a second, what we're going to do is we're going to hopefully switch over some cameras so the people online are going to be able to see what we're doing. But we have, there you go. Oh, that's really terrifying. We have a rather unwell person. So our plan is, and all the way along, is to try and show you a scenario this evening of CFR coming in, and then how it then progresses.
It's not the best.
It's not the best. Which, okay. Yeah, as we said, this is trial. I can only apologise if it all goes slightly wrong. Just to kind of give you a really brief bit of backstory. I'm really keen and have been, and I know that the guys in my team and the CFR training team know that we're pushing to do something called the pit view model, and we're actually going to do a video. So if any of you have ever seen it, there's a video online on YouTube by London Ambulance Service that shows the pit view model, and that's something that I've been pushing to try and do. So out of nowhere, I don't know how we've managed it, we've managed to get some funding from Learning and Development Education, Luke, education, somewhere, there's a pot of money that has been sent our direction. And now that I've made lovely contact with these amazing clinicians, so Luke and Emily and the other resource officers, we're eventually going to run a video and produce a video that shows this whole thing. So it will actually come from the east of England. So I think the fact that we can show from bystander to CFR through the whole process is key to why we do what we do. So this is going to hopefully start some way of showing you what it looks like. Like I said, please bear with us. We hope that it's going to work. So if you want to stand up and come forward, please do, or you can watch the online version. Luke has kindly also got a 360 camera, which he's going to record the whole scenario as well, which means online, those of you that are watching online, we know that you're probably not going to see the best, but what we are going to do is be able to record it and send it out again to you to be able to watch it. So if you want to stand up and come forward, this is going to give you the best opportunity to see it. Create a semicircle, come forward, bring yourselves forward. Luke's going to narrate it for us. So the idea being that this is going to run as a live scenario. Luke is going to talk through the process. So the CFR, the crew, whoever's coming in, they're not going to be mic'd up. So you're not going to hear them talking. But what you are going to hear is Luke talking through the process and what each person is doing. So, with no further ado, I'm going to welcome Luke back, and we're going to see what happens.
Thank you very much. Can everyone hear me?
I'll just hold it really close.
Can everyone hear me? Perfect. So you're probably not going to be able to hear the clinicians talking because they'll be talking to each other. So my aim is to try and narrate as much as is going on. Because they're all super professional, they're going to be doing a lot of things all at once. So I might just pick up the highlights from bits. If there's stuff that you see that I don't talk about at the end during it, then we'll have a Q&A at the end to pick up on any bits. All right. So first, I just want to say thank you to the people that have been nominated to take part in this. There was some element of having a choice. So thank you very much. So the scenario that we've got this evening, there's a gentleman who's been out with his grandson. They've been for a walk. We've got our grandson played by Josh here. And unfortunately, after the onset of central chest pain that's been radiating into the patient's jaw, the patient sat down. He's told Josh he's feeling unwell, and then he's become breathless. He's collapsed onto the floor. Josh, luckily, isn't here and has some phone signal and is able to make a phone call to 999. And then 999 go through. They'll ask some simple questions. They'll ask where he is, and they'll ask, is the patient breathing normally? And is the patient conscious? And Josh's answers to that are no, the patient is not breathing and the patient is not conscious. And then what we'll have is our amazing call handlers telling Josh over the phone to put themselves on speakerphone and to start doing CPR. They'll ask Josh if he's been trained before, and if not, they'll talk him through it. So they'll ask Josh to put his hands on the centre of the patient's sternum and to put his weight over the centre of the patient's body, get a good rhythm and fall in time with what they're counting. And they'll count 1, 2, 3, 1, 2, 3, around the rate of, how fast are we going? There are some good answers in 100 to 120. So they're going to carry on with that until help arrives, okay? And like we said earlier, this is the most important part of the cardiac arrest, is we maintain some of that flow so that when people arrive with an AED, we may be able to shock them. So luckily for us, we are in a village where there is a good community first responder scheme and someone is booked on. So whether they've had a pager or whether they've had a message through, they've been activated and they're making their way to scene. So as they arrive, they're obviously surveying the scene. They introduce themselves to Josh and they ask what's going on. It's really important with these cases that we do confirm that the patient is in cardiac arrest. So we'll see that happening in a moment. And then I'm just going to go quiet for a minute so you can hopefully have a listen to them talking. So we can see the CFR here doing a really good use of the bystander. He's had a look at the bystander CPR and it is good and it is effective. So he's utilising the ability for them to carry on doing CPR while he starts getting the AED out. So really important with this bit that we see good communication between the person putting the pad on and the person doing CPR, because we don't want to be off the chest for too long. So making sure the CPR carries on whilst we're preparing all of the equipment, and then a brief pause to be able to apply the pads onto the chest, like Nick and Emily went through, in a position where it's going to have effective defibrillation. Okay, and as we see the pads go on, we're then going to see the CFR using a lot of different devices, but all of them are going to have an element of analysing the rhythm, which probably means they're going to need to ask a person to come off of the chest, and then we're going to get that analysis.
Call emergency medical services now. Adult mode. Follow the voice prompt call lane. Remove all clothing from chest and stomach. Rip clothing if necessary. Take out the pads from the bottom of the device. Tear open the pad packaging. Look closely at the picture on each pad.
So really good use of the time here. We can see that the AED is obviously going through all of its automated things that we can't speed up with this model. So we're still carrying on with good effective CPR, and we see the CFR getting the oxygen ready to deliver to the patient, but also listening, so when the AED is ready to analyse, they're able to come off the chest to allow that.
The pad firmly to the bare skin of the patient. Look closely at the picture on each pad. Peel off the pad labeled 1 and stick to the bare skin of the patient, exactly as shown in the picture.
I'm being told that I might be the reason. Fantastic. Well, that was very informative to know how the AED works. It's now analysing the rhythm, hopefully. So the CFR has asked Joss to move away from the patient. Obviously, we need to make sure that we're keeping everyone safe during this point, so everyone is away from the patient. Okay, and we're reusing the bystander whilst we're going to start delivering oxygen as well. So we know that we can only really deliver good CPR for about 2 minutes before we start to get tired, and that's based on someone that regularly goes to the gym and doesn't eat Chinese takeaways. So for the majority of us, we are not going to be able to go past 2 minutes before we start to tire. So we need to make sure that we're swapping over CPR where possible, where we have additional people on scene. That might be police officers, that might be other relatives, or that might be the CFR. Luckily, we're in a position where we've got some of our first responders nearby. So Nick has been called to the scene. We've also got some other resources en route, but they're further away. So we see our rapid response vehicle with Nick on, who's one of our advanced paramedics in urgent care arriving. So similar to the time when the CFR arrived, we're just getting a brief history from the CFR to Nick, just to see what's happened. The reason we ask if there's already been a shock is because after a certain amount of shocks, we start to give certain treatments, certain drugs and certain different things. So we need to know how many have been delivered prior to us arriving. It's a good sign that nothing's changed and that Nick's obviously come in, seeing that there's a cardiac arrest being run really well with the resources that are there, and it's carried on using exactly what's being done, so using the bystander and using the CFR to oxygenate the patient. We're going to swap over the device onto our core pulse monitor, which is going to allow us to manually assess the rhythm and defibrillate it if we need to.
System shutting down.
Okay, so we see the AED going off, and I don't know if I need to press the button for that. The AED has come off the patient, and we've moved over to the core pulse. So we now see the paramedic looking at the rhythm that's on the screen. So the paramedic sees a uncoordinated, rapid and wide rhythm that looks like ventricular fibrillation, hopefully, and is going to charge that. Or didn't see that. I can't see the screen, so I might have gone off script. Perfect. So he did see that rhythm, and we're now charging. So CPR is going to continue. Really important, whilst we're where available, when we get our manual defibrillation, that we carry on doing CPR while it's charging. That allows us to get oxygen into the heart cells so that when we do defibrillate, they're in the best position to be able to get that heart to restart in the right rhythm. So we'll now see Nick looking at the airway and seeing if it's doing okay by itself or he needs to upgrade anything. And luckily we've got a DSA, so a double staff ambulance that's now parking and making their way into the location.
Hi guys, so we've got this chapter witness plan. There are 2 shots, one off the AV, one off the VF, and we're now into second round, 40 seconds in.
So what we'll start to see now that we've got more resources on scene is we'll start to see some roles being allocated. The things that we weren't able to deal with that weren't immediate needs but are now things that we can take on board. So swapping over our rescuers, making sure the CPR has been swapped every 2 minutes, having a look at the airway and making sure we have got the most effective mechanism to get oxygen down into the lungs, and if need to, escalating that, or potentially using things like suction to clear the airway. We see a lot of times in our patients that arrest suddenly, that if they have eaten earlier or if they've arrested very quickly, that they may have a soiled airway, and that may be due to food from earlier. That might be that they've eaten quite a lot, and as they lay down, they get some gastric emptying, so what's coming back up from the stomach and sits in their mouth. Most of you may have seen that on patients as you start to ventilate and you hear a bit of a bubbling and you see a bit at the back of the mouth that may need suctioning. Luckily on this patient, I don't think there is that, so they're going to carry on with the I'm not meant to move. They're going to carry on with the technique that they're using. So they've upgraded the airway to an iGel, I think, which is a device that's used to allow the plastic element of it to sit directly over the trachea to allow us to put oxygen straight down into the trachea. So one of the benefits of that is that it has a very good seal in most patients around where we want the oxygen to go. So whereas when we've got the BVM, sometimes we get a leak out the side. With having the iGel in place, it makes it a lot easier to be able to get the oxygen into the right place and not down into the stomach or the esophagus. So we've just got to another rhythm check. And if we have a look at how they're doing it, everyone's nice and calm, nice and coordinated. We see the CFR actually using those essential skills. This isn't something that once we've turned up, we say goodbye. This is something that's now a teamwork, and we're going to rotate between us. We're now seeing some additional interventions being undertaken. So Emily is gaining intravenous access in the left arm, which is to allow us to give some drugs. So the patient has received, Justine, 3 shots? 3 shots overall. So 1 from the CFR prior to the clinician's arrival and 2 from us. After we've had 3 shots, we're going to start giving some specific drugs. One of the drugs we're going to give is amiodarone, and the aim of that is to try and make our heart a little bit happier, essentially to make the rhythm that they've been in, that uncoordinated VF, to make it a little bit slower in how it works, so we can hopefully, when we defibrillate it, knock it back into a normal rhythm instead of being that very excited rhythm that's likely to be not really helpful for getting a pulse back or a ROSC. Also going to give adrenaline at this point. So adrenaline is given for a variety of reasons. One of the things we're looking for in this case is to allow us to have a little bit more squeeze on some of our vessels, which we know get a little bit leaky in cardiac arrest, to allow that blood flow to work as we're pumping and doing CPR. So hopefully we can see a nice coordinated, calm scene. The aim of having our roles is that we don't need to move too much once we've got into position. So we can be on both sides of the patient and we can swap CPR every 2 minutes. We can defibrillate from the head end or from our clinician at the side by the defib. And looking back to the talk you had from Emily and Nick, looking at really clear communication, so the ability to say a few amount of words that make sense to everyone and convey the message without being too overly complicated. Is everyone clear? Shocking, shocked, back on the chest. So nothing overly intensive, but just to make sure everyone's aware of what's going on. So we've this has gone through to obviously a lot of resources. We've got lots of different resources en route to this. One of them is our leading operations managers, and they're just arriving on scene now. That's Adam. Adam brings with him so additional kit, so the mechanical CPR device, also the ability to intubate if required in our patients, and they are also a resource that's targeted at cardiac arrest, so they see a lot more of them. We do have en route as well one of our volunteer CCPs from SARS, which is our local basics team. They're about 5 minutes away, so they'll be getting here shortly. So you might be able to see potentially on the camera from one of the views, or if you're in the room and nearby, we've now got the checklist out, and we're using that as a nice, calm, algorithmic approach. We're all human, we all forget things, we all get our bandwidth maxed out with everything that's going on. This gives us the ability to look and make sure everything's being done. If you get an opportunity later, have a look at it. There's nothing over complicated on it. It's, have we allocated roles to each other? Have we made sure the airway has got a patent device in? Are we making sure we're shocking the right rhythms? Have we got an end tidal? So an end tidal carbon dioxide reading to make sure we're getting oxygen coming out.
I'm just going to update CCP.
Okay, so Emily's just given CCD a call, which is the channel that we use to contact our basics and our critical care resources, just to make sure that we get the essential skills that they're able to deliver to the right patient. She's told them that we've got a patient who, despite being shocked 4 times, they've been unable to get out of ventricular fibrillation. So they think they might need the additional skills that the CCP might bring. And luckily, due to finding a shortcut, they are now on scene.
So that's our 50 total, so she's happy with small shots.
I'm Gemma, how can I help? Hi Gemma, hi. This is manual witness.
So we've got a nice, calm environment. No one's shouting. Everyone's able to speak to each other. Obviously, me speaking over them on a microphone doesn't particularly help, but you can see that clear communication is working because they're using each other's names. They're talking directly to the other person they're trying to get attention of, and they're speaking in nice, clear sentences and just saying what they need. Emily's given a handover to Gemma, our CCP, and she's just asking about some things that we may be able to change to potentially get this person out of ventricular fibrillation. So following a handover, Gemma's had a chat about the patient, and she's able to deliver some additional drugs that we wouldn't carry on normal ambulances or our response cars that might support the patient's heart to move into a more stable rhythm once we defibrillate it again. She's also talked about some different strategies, so potentially moving the pads from the normal position that we would see them when we would put them underneath our right clavicle and underneath our left armpit, but moving them into a different position, which we wouldn't advocate to be done normally within most people's scope of practice. But for someone specific to this that has lots of shock from a critical care perspective, we would start to essentially change the direction of the electricity to see if it's going to have more of an effect. That's something that obviously is delivered with additional training and competency. One of the main things that's really important when they put the mechanical device on is making sure that it's in the right place. And the way they do that is by checking the end tidal before they put it on, so the end tidal being the reading of carbon dioxide that the patient is blowing off, and then checking it after. We know if they've got a good end tidal reading after the Lucas has been put on, then we're getting a good squeeze of that heart and we're getting good circulation. If the end tidal's got worse, we know the Lucas is probably in the wrong place and we might need to move it. So we now see Emily gaining our intravenous access on the other side as well. That allows us to deliver another range of drugs at the same time, so we haven't just got one site of access. It also means if due to any accident, us walking past or the patient moving, when we defibrillate them, we're not going to knock out an intravenous line and not have any way to give any drugs. I think I might have missed it, but I think we've delivered a second amount of amiodarone and we've also given some more adrenaline. We've had the magnesium going in from Gemma, and Gemma's now preparing to undertake an endotracheal intubation, which means putting a tube straight down into the patient's trachea and then blowing up a cuff. This is the same kind of airway management you would normally see in general surgery under general anaesthetic, and that means that there's no interruptible passageway between Gemma squeezing the BVM and the patient's lungs, which makes it a lot easier to deliver oxygen without having to squeeze too hard.
Okay. Happy to see you.
So one of the good things about using the mechanical device is that we can keep it on doing CPR during defibrillation. So obviously when we defibrillate and humans are doing CPR, we need to come off the chest, but this gives us the ability to continue doing compressions and get good blood flow during that the defibrillation. So as we see Gemma starting to look down into the patient's mouth with the laryngoscope, one of the things that she'll be aware of that she's now not able to look at the defibrillator. So that task has been handed over to Nick to keep an eye on the defibrillator. We know that when someone starts to do something that's quite skill focused or quite heavy on your bandwidth, you can't be that person to run that cardiac arrest because you're doing a specific skill. So at this moment, Gemma's sole kind of aim is to get that tube down into the trachea. She's been assisted by her airway assistant, and we've got the rest of the team monitoring the rhythm on the CPR and having a look at the timings. Timings are really important for us because we use that to gauge when we're giving our drugs, and also when we start making decisions about should we take this patient to hospital in cardiac arrest or should we be expecting to be making different decisions. So a really good point's been made by Emily now. So she's just asked if anyone's spoken to the relative, and I don't know if anyone noticed, but Josh was probably one of the most composed relatives that we're likely to get, and kind of took himself off of scene. This isn't very normal. We'd normally have someone asking a lot of questions, and it's a role that we probably haven't given enough emphasis to in the past. It's someone that we should, obviously we get a lot of history from them, so that's going to help us to understand what's gone on with the patient. Like you were speaking about earlier, the ability to understand what happened before the event. But we also need to ensure we're looking after all of the patients, which includes psychologically the patient's family and relatives. It might not be a family member, it might be a co-worker, it might be someone that they've just met, but we need to make sure we look after everyone. So alongside the clinicians we've got here on scene, an arrest in the community would normally bring a police response to it. All of our police services across the 6 counties are really supportive of getting there early. Most of them carry AEDs as well, and they will all undertake CPR and basic life support prior to our arriving. In some areas, I don't know if we've got any Norfolk folk here, and also in Hertfordshire, and it may be elsewhere and I'm not aware, so apologies, but we do get the fire service coming out as a model as well, where they come out with the 6 of them on a pump to deliver essentially a very good CPR machine until we turn up. So the ability for everyone that's able to turn up gives the patient the best outcome. So I'm just going to recap with Justine just to see how many shocks we've had. Okay, so we've had 7 shocks now. The patient's currently being intubated. And they're just discussing moving the pads into a different placement. So I think that's going to be undertaken once the intubation's been successful, or they move back down to an I-gel. It's really important with airway management. Obviously, Gemma's recognised the need to upgrade the airway, but we make sure that we use whatever's available to get oxygen down to the lungs. Sometimes we'll try and attempt, and whether it's due to the patient's anatomy or, like we said, soiling in the airway earlier, we may not be able to pass that tube, in which case we'll go back down to an I-gel and use what we can to get oxygen in. But I think we've been successful in this case. So we've got an ET tube in the airway, and what we'll see now is a series of confirmation checks to make sure it's in the right chamber, because essentially our airway sits very close to our esophagus, and it's very easy to mistake one for the other when it's a dark tunnel. So you'll see Gemma looking at the end tidal. You'll see her ventilating the chest to make sure we've got chest rise. You'll see her listening and auscultating both sides of the chest with her stethoscope, and also looking for confirmation from her colleagues. If there's anyone concerned that it's in the esophagus, then there's a flattened hierarchy. There's no leaders and there's no followers. Anyone can challenge and say, I think that's in the wrong place, and then we'll come out, because that's how we get patient safety. So we've now got an upgraded ET tube in the patient's airway. The patients have magnesium. They've had 2 amiodarones. They've had some adrenaline. And the patient is in. Patient's still in a shockable rhythm. So we can see Gemma prepping a ventilator. So the benefit of the ventilator is it gives us the ability to use a machine to start undertaking the ventilation. What that means is if the patient isn't out of this this shockable arrest, and we feel that it would be appropriate to get them, say, to a cardiac catheterization centre or to a cardiac arrest centre where we have them, we can start ventilating the patient whilst moving them. We know when we try and do things whilst moving and we use humans, it's not very effective. We can't ventilate well when we're trying to go down a staircase, and we can't do CPR well when we're in the back of a moving ambulance. And that's the benefit of using things like ventilators and the Lucas device. So I think when we come up to the next rhythm recognition, I'll just be quiet for it and we'll have a listen to what they say. So we can hear Adam. So one of the things you may hear on cardiac arrest is people talking about reversible causes. So there's a lot of things that can cause cardiac arrest. We can't rule out all of them and we can't deal with all of them, but there's 8 that we will normally try and cover. And one of them is a thrombotic event in either your coronary arteries or your pulmonary vessels. So the coronary vessels would be obviously a heart attack, a myocardial infarction. And there's a strong indication from this patient who had an onset of radiating centralized chest pain that was quite sudden and then was noted to collapse suddenly, that they feel this is probably due to a coronary event. So because of that, they're now talking about destinations and what to do with this patient if they aren't able to get them out of cardiac arrest. Some of these patients do really well if we transport them intra-arrest to the right centre and we're able to open up the coronary vessels. So putting a wire down through the femoral or the radial artery up into the heart and then unblocking it with a stent. If anyone's had any coronary stents or know anyone that has, that's essentially what they do. It's a little bit more difficult when you've got a mechanical machine doing the CPR. But essentially, if this patient's heart needs to have the vessels reopened, then we need to get them to the right centre to do that. But I think in this patient, they've just done a rhythm analysis and we've now got a rhythm that is conducive with life, which means that potentially if we can find a pulse in this patient, that this patient has had a ROSC. Some of these patients will have a rhythm that looks normal, but we can't feel a pulse. And that means that there's electrical activity at the heart, but there's not any muscular movement. So sometimes we need to give some additional drugs or some additional treatment options to try and get that heart to move by itself. One of the things that Gemma, the critical care paramedic, brings with her is an ultrasound. So in patients where we can't find a pulse, but we do have electrical activity, we can see the use of an ultrasound to have a look at the heart, to see what's going on with it, to see what shape it's in effectively, to see whether it's a healthy heart that just needs a bit of support, or it's a heart that's had a lot of stress and has probably been unwell for a very long time. And we use that decision to help prognosticate with some of our patients. So I think, I can't see the screen, but it sounds like this patient is in a tachycardic rhythm, so a fast heart rate. I think they're now just going to undertake a quick A to E assessment, which is part of our post-ROSC care. So now we know we've got the patient into a position where their heart is beating by itself. That doesn't essentially mean that they might be breathing by themselves. It doesn't mean that they may be conscious. Obviously, the longer we're in cardiac arrest, the more hypoxic our brain gets. So potentially we may have a large amount of time where this patient is unconscious. So they're going to undertake an A to E assessment, which might be done by one of them or it might be done by the whole team. Essentially, starting at A, they're going to look in the airway. We know they've got the endotracheal tube in the airway, so they're going to recheck that and make sure it's patent. They'll do that by squeeze in the bag and making sure we've still got lung movement. Sometimes, as they probably talked about earlier, if we squeeze the bag too heavily, we put a lot of oxygen, a lot of air into people's lungs, and we can cause damage, which is why it's really important when you ventilate that you only use a small amount of that bag until we get a little bit of chest rise. If anyone hasn't had the opportunity to have a play with the ventilation, dump the mannequins at the side, you can do that after this. So once they've done A, they're moving on to B. They want to see if the patient's breathing by themselves or if they're needing to assist the patient's breathing. In this case, the patient isn't breathing by themselves, so Gemma's going to maintain them on the ventilator. The ventilator settings are very complicated, but essentially they're going to turn some of the dials that relate to how quickly we ventilate them and how much we squeeze with each vent to make sure they're having the right level of end tidal, so carbon dioxide that they're breathing off. They're then going to move on to C. So C is circulation. They're going to have a look at the heart rate. We see them doing a blood pressure and they're also doing a 12-lead ECG. So if you've been to a GP before for chest pain, or if you've got any cardiac history in the family, you may have had an ECG, or you may have seen one with the patient. Essentially, it is a digital picture of your heart from lots of different angles, and that's to have a look and see what's going on with your heart. It measures the electrical activity in different directions, and it's able to tell us if there's any acute events going on. I think on the ECG that they're about to print out, they're going to find that there is a myocardial infarction in one of the zones of the heart, which essentially means that one of the coronary vessels of the heart is blocked, which is probably what's caused this patient's cardiac arrest. Once they found that out, and I think I might have just given them a spoiler alert because I haven't printed it out yet. Once they found that out, they are going to use that to make a decision about which hospital they're going to. So a patient that's had a myocardial infarction and then a cardiac arrest doesn't need to go to the local hospital. They need to go to a specialist cardiac centre. So these are the patients that sometimes it may not make sense to you, but they'll be bypassing the local hospitals, potentially several local hospitals, to go to the PPCI centre. Once they've had a look at C, they're also going to finish their assessment. So they're going to move on to D, so they're going to look at disability. They're going to start looking at the pupils of the patients, potentially with a pen torch. We're looking to see if there's any reaction to light, and if that's the same on both sides. This might seem silly because we know the patient's unconscious, but essentially we need to know what they're doing now, because in 12 hours, 24 hours, 72 hours, we need to see if there's an improvement when we start prognosticating the patient and we start potentially weaning them off of their anaesthetic. Within D, we're also going to look at their temperature. So we're going to potentially do a temperature in their tympanic, so in their ear, and we'll also do a blood glucose in some patients to just see if this patient is potentially diabetic. So diabetes doesn't primarily cause cardiac arrest, but it can cause seizures, it can cause hypoxic events that can then lead to cardiac arrest. So we need to make sure this patient isn't in a diabetic emergency. They're then going to move on to E, and one of the things we look for in E is expose and examine. So this doesn't sound like anyone that's going to present with any stab wounds, any trauma, they've not fallen from a tree, but we need to make sure of that. We don't always know that Joss, the nice relative, actually told us the truth. So we just need to make sure as we're packaging them that we haven't got any additional things. And it might be accidental. A fall from height from someone over the age of 75 can have significant trauma to the head, because we know that their bone structure hasn't got as much strength to it and there's not as much muscle that sits around it. So we need to think even about those falls from standing in our elderly patients can cause trauma. So it's really important to have a look at their back, have a look at their neck, and fully expose them. So one of the things that's been happening while I've been droning on is that the blood pressure of the patient has been quite low. So we know they've got a pulse, we can feel their pulse in their arm and in their neck, but that pulse is quite low. So we know that for the brain to get enough perfusion and the kidneys to get enough perfusion and the heart, we need the blood pressure to be at a certain level. Currently, it's not. So one of the drugs that our paramedics are able to give is adrenaline, but in a different way. So we can use it essentially as your large shot of coffee every morning you use to get out of bed. And that's what we're doing to the blood pressure with the adrenaline. It's given a small amount of adrenaline, probably every 3 to 5 minutes, just to help that blood pressure stay at a level where it's able to perfuse the essential organs. The benefit of having Gemma here is she's able to give us a syringe driver, whereas instead of just doing lots of slugs of adrenaline, so our blood pressure does this, it has a nice constant amount of adrenaline going through, so we can maintain that blood pressure. It seems like the crew are now ready to leave scene. So I think we'll stop there if everyone's happy. Can we give a round of applause to the crew and to our CFO as well? Well done. Perfect. So I think, do you want a Q&A with these guys? Or?
These guys tidy up, but we'll do a Q&A, I think. Yeah.
Perfect.
Yeah, happy?
Yeah.
We'll just, if you can stay. I've got no idea what I'm answering. We'll just let everybody take a seat and then have a think, because I'm sure there's probably questions, possibly. Anybody feeling brave enough to stick a hand up and ask a question? No questions? No, not one. Yes. Well, so
they can multitask.
They can multitask.
So it's two things really, just that I noticed a big difference from what we did. The first was the doing compressions whilst waiting for the job. We're not trying to do that. I mean, it's we shouldn't be doing that with an AED?
So if you just want to repeat the question.
So the question was, obviously we saw in the video that when we use the defibrillator in manual mode, that we're able to do CPR during the shocking phase. And it's not as much about scope here as it's about the modes that we use them in. So in AED mode, if we start doing compressions while it's analysing, so essentially what we do as a human in the manual mode, it messes up the computer. Because we're moving the heart mechanically by ourselves, it won't tell you whether it's a shockable or non-shockable rhythm. That's not to say there's not technology that's coming that will allow us to do CPR during charging, and actually some of our Zoll AEDs that we're looking at probably over the next few years will give us the ability to do charging while CPR. So it's not as much a scope question as a mode question. When our clinicians turn up, they finesse what we're doing by using it in manual mode. That doesn't make it any less effective or more effective, but it's a really good thing to pick up on, that we are able to do a little bit more CPR during the charging phase, which is why we move over to manual. One of the risks of moving over to manual is we might get it wrong. We're all human. Not all rhythms are as easy to look at as sometimes we think they are as clinicians. So there is sometimes a benefit. And if you go to a patient that's in quite a stressful situation, I've certainly put my core pulse back into AED mode as a professional, because it gives me one less thing to worry about getting wrong when you're on your own, certainly, especially in some of your paediatric cardiac arrest. So it's not as much about scope, it's more about just the mode we're using it. And as a CFR or as some of our non-trained clinicians that might turn up on an ambulance, we use it in AED mode for that reason. Does that answer?
It does, yeah. I did just have another.
Yeah, go for it.
This was just more a point of interest, maybe. So when we're doing BVM, if we're doing a shock, we have to remove the BVM from a metre away from the thing. I know when you're using iGel, you're obviously not worried about the oxygen. Is there a reason for that? Yeah, so we're a very safety conscious profession in healthcare because we don't want to defibrillate our colleagues. I think that's the first point. But historically, if we go back several decades, we use paddles, and the risk with paddles is that they arc. So electricity will go to the path of least resistance. If your paddles aren't pointing directly onto the chest, you will get arc across, which is historically where we've shocked a few of our colleagues, I've been told. So the reason that we don't ventilate with a BVM is because we're introducing a potentially flammable gas into a zone that they're potentially, and there's a lot of potentials in the statement, could be arcing. There's not been any cases of arcing in pads since they've been introduced, and some systems outside of the UK do carry on using oxygen. But for yourselves and for the Resus Council, which is what guides all of us as paramedics, we move oxygen delivery circuits away, at least you say a metre. When we introduce an iGel, or even better an ET tube, essentially that is a closed circuit going down. And there's a caveat to that, because if you don't put it in well, it's not a closed circuit. So you need to make sure that it's in the right place, it's down firmly. So you would have seen there was a bit of a check between them just to make sure they were happy the iGel was in before they left it. So that's the reason we leave it in when it's on an iGel or on an ET tube, but we remove it when we're BVM. Does that answer? Perfect. That's what I'm about.
Yeah, thank you. Anybody else, any questions? No one else has got any questions? No? Wow, okay. Yeah, of course you can.
So what we normally do after a job is a debrief, which I think sometimes we, whether you've left scene because you've gone to carry on with whatever you were doing in your day, you've gone to pick up the kids, or, you know, as much as we like to think we think of everything, sometimes we don't think of everyone involved. I think we do miss out the CFRs in the debrief. So we're not going to do a whole debrief, but I'm just going to run through with the team what we cover. And what I want you to take from this is the confidence to ask to be part of the debrief in every cardiac arrest you go to moving forwards. Because the aim is to give you closure, to give you answers, and to give you that psychological support afterwards. So can we, Jim, are you happy taking this one just to talk about debriefing? So this is what I mean about nominating people. But so I picked on Gemma just because of her role as a CCP. She's going to have undertaken a lot more debriefs than me. So I'll pass you over to Gemma.
It's very sweaty.
You just come this way a little bit.
Sorry, you'd think I might have prepared, but I was unaware of this. So, from my point of view, the most important thing when we do a debrief is everybody goes away happy. No one goes away without something on their mind that they didn't get to bring up, a question that they didn't get to ask. So it's important to make sure that you've created an environment that allows those things to happen. So I would suggest that you move away from the family, move away from the general public, to be quite honest, which is why this will often be conducted in the back of an ambulance. Excuse me. So we tend to usually run through the job almost from start to finish and to draw people into the conversation. So I would probably begin with our our CFR colleagues and ask him to give me the history of what he found when he got there. Did he have any problems? Was there anything he worried about? Then he would have handed over to Nick, and I'd ask Nick the same thing, just to talk me through perhaps some of the decisions he made and I guess how he came to those conclusions. And then we'd run through each sort of clinician that came into the scenario through that way. Depending on what's happened, whether the patient has unfortunately been pronounced life extinct or if we've gone to hospital, we then might talk a little bit about if there was anything, if we could do it over again, what we might change, if there was anything that we thought went really well. So you might suggest to one of your colleagues that you really liked the way that it communicated, or I hadn't seen somebody do it that way before. Can you talk me through why you made that decision? So it's just a real open forum. There doesn't really need to be a set criteria of how you go through it. You'll find each one of the clinicians will do it slightly differently. And at the end, again, you always ask that open question, is there anything else anyone wants to bring up? And certainly from a leadership point of view, if you are the manager on scene, you would then follow that up with, if there's anything that comes up later, tomorrow, the next day. You have all experienced difficult jobs like this. And I think one of the phrases I always say is, however you feel is okay. You might be feeling elated. This is the job you signed to do. You wanted to go and help people in cardiac arrest, so you might feel quite pleased and happy that happened. And that's not something unusual to feel, because that's why you've signed up to do this. But it might be that 2 days later, you start to feel bad about the job and you can't get that patient out of your mind. And then that's the time to reach out and ask for help. And that's what our trim services are there for, and your team leaders within your groups. But at the end of the day, when you turn up, everybody turns up to do their very best. We'll all make mistakes. Sometimes things won't go well. Don't know if you noticed, but that was a very difficult intubation. I think they've hidden something down.
I was going to say, yeah.
And that will happen. That will happen. So yeah, it's just a really important time to be able to get anything off your chest, to understand things that perhaps you didn't understand. And the point that Luke makes is really, really important. Sometimes we will be a bit task focused. Don't rely on us to find you and include you. Step forward. You are part of our team in the East of England. You absolutely are. And I hope you will go away feeling that today. So yeah, step forward. We'd like to include you.
Thank you. So I think it's fair to say that's quite a sizable amount of information that we've possibly had this evening. I don't know, information overload. I just want to say, so we're going to draw the evening to a close, because I don't know about you, but I'm really hot and I need a nap. I just want to say thank you to everybody that's turned up tonight, because 4 months ago, I sent an email to lots of people and said, please could you come and help, because it'd be really good. And I didn't get a response. And I was like, oh, this is really awkward. And look at what we've got that's up here with us this evening. So thank you to each and every one of you that's here that has stepped up tonight and come out and done this for us, because genuinely, I know as a CFR, that will mean a lot to the guys in the room, to the people online, that you've come and given your time up. So thank you. So I think a round of applause. The last one, I'm really sorry, the last one, we got flowers for our speakers, but I've got to be honest, I don't have a budget for, we spent it on cake. So I'm really sorry. I'm sorry. There's cake. There's still cake. Okay. So thank you for tonight. Thank you for taking the time to come out. I'm really glad it's not flooded, and I'm really glad that we're all here. It's really, really lovely to see you. If I could ask one final thing from you, when you came in, on your chairs or near to you, there was a piece of paper with a QR code. Could you pretty please either scan it, take it away, and feed back to me what you want to see? Yes? Does it not work? Say that again?
The email address is slightly wrong.
The email what, sorry?
The email address is wrong.
There's a dot between east and am.
There's a dot between east and take. Oh, what? Can't get the staff.
I work for the council.
Yeah, I was going to say, I don't know if I ever introduced him, my husband, who doesn't work for the NHS. Who has kindly donated his time. So yeah, could you fill out the QR code? This came about from Harlow, and the people watching at the Harlow at the stroke evening said that they wanted to see this, and that's what the majority of the kind of consensus was. So tell me what you want to see next. Mike made the off-the-cuff comment that we'll put one on next week. We are absolutely not. We will consider March next year, not going to lie. But thank you. Drive safe. Thank you to everybody online. Thank you to the guys that have come this evening. Genuinely, really, really, genuinely appreciated. And it's nice to actually put names to faces. Yeah. Yes.
Hello, everybody. My name is Jeremy. I'm regional vaccination lead for this year. Thank you very much for everybody that's had their vaccines this evening. For those that are not having their vaccine or are having their vaccine elsewhere, can you please inform? Because all of your numbers, and there are 1,300 of you involved within Eastern England Family Service, all on our audit. Yeah. So what we'd like to contact every single person. So if you're not having the vaccine released, all you need to say is, no, you're not having the vaccine released. If you've had it elsewhere, that's sort of information that we need to know. So for all those that have had the vaccination this evening, thank you very much for taking up the opportunity. If you still have vaccines left, if anybody wants more vaccines tonight. But if you're not having the vaccine released, can you contact us and inform us if you're not having it?
I'm just going to say actually, I'm really sorry. You were hidden in the corner and I completely forgot about you. I'm so sorry. Totally. The gin and tonic's calling. I'm so sorry. Thank you for coming, genuinely. Are you all right to just repeat what Jeremy's just said for me? Is that all right, just so that these guys...
Yeah, definitely.
Just
So
that
I can repeat it too online, but I don't think the flu vaccinations are available to you at home this evening. Just double check with Jeremy. No, he isn't doing that service.
You're not going to go round?
I just wanted to take a moment before everyone starts going off, just to have a round of applause, preferably standing, for Liz for the amount of effort that's been put in. And also to her husband, who I think was also been following on. Thank you very much.
Thank you. So thank you. Drive safe. Apologies, Flu Clinic. Thank you for coming. Really appreciate it. And have a safe journey. Take care.